continue letting people in. We still are waiting for a few more committee members, but you can go ahead and take it away, Debbie.
Thank you, Katie. Good afternoon and welcome to the Plan, Design and Expenditure Committee of the Universal Health Plan Governance Board. My name's Debbie Diaz. I'm a member of the Governance Board and the chair of this committee. This is our second committee meeting, and I want to welcome you all back, committee members, staff, as well as any members of the public that are joining in. The primary goal of this meeting will be to, one, gain a greater understanding of the PEB benefits, which were a recommendation from the task force and are included in the preliminary structure adopted by the governance board. And second, to start discussing some of the priorities of the benefits and options for adding or reducing benefits if needed once the Finance and Revenue Committee has a plan. Before we get started, I'm going to turn it over to Katie DeLuca, who is providing support for the committee to do a tech check.
Thank you so much. I'm still letting committee members in, so some of you may not be able to connect your audio and camera yet, but for those of you that can, thank you for being here. And just a quick reminder about Zoom. We do have members of the public joining us today. They're just not able to participate. So if you could please start your video if you're able. If you can't, that's okay. But if you're able to start your video, then people will recognize who committee members are. And then just a reminder that select the raise your hand function, and then you'll be called upon, and then you can unmute yourself. Please stay muted until you are called upon to speak. If at any time you have any technical difficulties, please reach out. You can send me, or you can email the info email, or send me a text message, which my phone number will actually be on the screen a little bit later. So I'm actually going to go ahead and just go right into roll call, if that's okay with you, Debbie.
Go for it.
Awesome. I'm just going to make sure that all committee members are able to connect. So just one moment.
It looks like Betsy Boyd Flynn has a hand raised.
She may be just trying to say that she hasn't connected yet.
Okay.
But we'll get to her in just a moment. Okay. I'm going to go ahead and jump into roll call, and then just today's question, we're going to do a little tiny get to know you question, something short and sweet. But when you are called upon, please share what your favorite dish was on Thanksgiving. So we will start with Debbie Diaz.
Thank you. Debbie Diaz, I use she, her pronouns. And my favorite dish this year was actually, I guess it's more of a side dish. My cranberry sauce came out really, really good. I put some extra orange and spice. And I don't know, the cranberries were just better this year or something, but there was something special about it. So I will toot my own horn there.
Nice. Thanks, Debbie. Dr. Rosemary Hemmings.
I'm here, present. And what was the question?
Your favorite dish you had on Thanksgiving this year?
I can't remember, actually. Sorry.
Oh, that's totally fine. No problem. All right. Angela McCulloch.
Hi, Angela Mahalik. I use she, her pronouns. Yeah, we were at the beach, so I just had like a salad bowl. We didn't do any cooking. That was the treat of Thanksgiving.
That is a treat. All right. Antonio Germain.
Yeah, hi, good afternoon, everybody. Tony German, he, his pronouns. I'd have to say the stuffing was great this year.
Thank you very much, Tony. Betsy Boyd Flynn.
Hi, Betsy Boyd Flynn. I use she, her pronouns, and I would say my favorite thing was the giant sheet pan pie that I made. That was actually 4 pies in one: pumpkin, pecan, apple, and cherry. It was pretty good.
Wow. Thank you so much, Betsy. Brian Frank.
Sorry, can't find the mute button. Brian Frank, he, him. I made a sweet potato casserole with marshmallows because
Classic. Love it. Christine Zinter.
Hi, I am here and we went to Canada for Thanksgiving because that's called Thursday and we avoided family.
Love it. Eve Gray.
Eve Gray, she, her pronouns. I liked the pumpkin pie cheesecake.
Yum. Thank you. Gabriel Andine.
Yeah, Gabe Andine here. I gotta agree with you. The cranberry relish was particularly good, and I really think adding the orange to that is what makes it.
Agreed. Jim McGee. Okay, we'll circle back to Jim. Jamie Osborne.
Good afternoon, Jamie Osborne, she, her pronouns. Yep, it was the cranberry sauce.
Thank you, Jamie. Julianne Horner.
Hi there. I would have to say that it was the apple pie for me.
Thank you. Max Kaiser.
Hello. He has probably the stuffing, and I'm not particular about it. They made a fancy one, but I'm fine with out of the box too.
Thanks, Max. Mike Durbin.
Good afternoon, Mike Durbin. He, him, his pronouns. Definitely the stuffing.
All right. Thank you. Peter Addy.
Hey, good morning. Peter Addy, he, him. For National Day of Mourning, I made some vegan pumpkin pie. It was great.
Thank you. Peter Merritt.
Hi, everyone. Peter Merritt, he's, he, him pronouns. A friend of mine made a peanut butter pie with Oreo crust that she described as cream cheese forward. It's the kind of thing that you can have like 2 bites of before you're kind of done, but those 2 bites were really good.
Thank you. Rob Fissette.
Hello, Rob. He, him. It was Thursday, so we had mac and cheese.
Thank you. Tosh Raman.
Hi, Tosh Raman, he, him pronoun. My wife made a sweet potato pie for Thanksgiving, which was really good.
Awesome. Helen Belanca.
Hi, everyone. Helen Belanca, and I'm in the crowd with the cranberry orange sauce. It was really good.
Great, thank you. We also have Cheryl Ramirez and Shunwei Chi on the committee, but they both have previous engagements right now. Cheryl will be joining us a little bit later. But with that, that is everybody, and I will turn it back to Debbie.
Thank you, Katie. And I will actually turn it over to Morgan Cowling, who is working with our committee and will introduce our staff and contractors who will be working to support this committee.
Great, thank you, Debbie. And I just to follow up, I did see Jim during the introductions, and I think he may just have been on mute. Jim, did you want to?
I was on mute. I hate talking to myself. But I seem to be the only one who is going to single out the turkey. My brother-in-law made smoked turkey, and it was wonderful.
Welcome. And I do want to reintroduce the staff that's supporting the committee work today that you'll see in the breakout groups and presenting. We have our colleagues from the Oregon Health Authority, Jessica Marino and Danielle Ross. And we have 2 contractors from Health Management Associates, Anya Rader Wallach and Janine Smith, who will also be supporting the committee today.
Thank you, Morgan. So looking at our agenda for today, we will hear from Morgan regarding an update to some of the board policy changes. Additionally, we will be having a presentation by Anya Roder-Wallach with HMA to discuss the overview, or rather present the overview of benefit options. And then we will have a short break after that presentation and reconvene and actually do some breakout groups to further discuss the presentation. And then after those breakout groups, we'll be coming back in to have kind of a larger group debrief of those individual group discussions. And then we will just kind of follow it up with anything that comes from that, anything that might, any additional questions that are brought up from the various groups that might need to be addressed. And then we'll switch our focus to our next planned topic for next meeting, which is overview of eligibility. As always, we'll leave a moment for any committee member reflections or feedback. And then I do believe we did not receive any public comment for today, so that won't be necessary for today's meeting. So with that, I will go ahead and hand it off to Morgan to go over our board policy changes.
Great. Thank you, Debbie. Katie, could you move the slide along? Before I go into the policy, I just wanted to provide a quick refresher and a little background. The Oregon legislature passed a bill during the 23 legislative session that made some changes to public meetings law and defined convening more broadly than it had been defined in the past to include serial electronic communications that can happen over time and the use of an intermediary. With those changes, it is much easier to have a meeting convene and to reach a quorum, you can reach a quorum and have an unnoticed public meeting easier than in the past. I'm not going to go over the background on that change. We covered that in the committee orientation, but I just did want to reference that for some of the rationale for the policy change. At the beginning of the year, at the first meeting of the governance board, the legal counsel for the board advised the board to adopt a communication policy that suggested that board members and committee members should avoid communication. The policy never said that board members could not communicate. However, it did suggest really limited communication so that convening of a quorum through serial communications or the use of an intermediary wouldn't happen. There have continued to be lots of questions about that policy and how that policy would be implemented and how the board could do its work. So during the November board meeting, the governance board had a lengthy conversation about the policy and updated the member communication policy to more directly address the issue of member communications. And you'll see in this policy, the board upholds their commitment to transparency, recognizing the important work that needs to happen and that some limited communication among members to facilitate the board's work and accomplish its deliverables is necessary. So again, it explicitly lays that out in this policy. The policy also suggests that members of the board and committees take advantage of the public meeting law training offered by the Government Ethics Commission. So we are in the work staff is in the process of developing a one-pager that can answer some frequently asked questions about this. I don't want to go into too much depth about this, but to say if after taking a look at this policy, you have questions, you can email the UHPGB info email that goes directly to Katie. That will be helpful for us as we develop this one pager to see what questions are still out there. And then if you have specific scenarios, the Government Ethics Commission is actually encouraging people who are sitting on committees and boards to email them. It will help them as they continue to roll out the training and make sure that they're meeting the needs of people who are serving on boards and commissions. So I just wanted to let you all know that that change happened at the last board meeting, and there will be future communication coming out to all of the committee members shortly. Thanks, Debbie. It's me again. Do you want me to keep going?
Yeah, I was just going to say, I don't think I'm not going to hand it from you back to you.
All right. Well, now switching gears and jumping into today's topics, we just wanted to give a refresher of the committee tasks and timelines before Anya takes it over and does that deeper dive into benefits. Next slide here. We talked about this process for the first phase of the committee at the last meeting, that we're going to spend the next several meetings doing a deeper dive into those plan design components that were recommended by the task force and then adopted by the governance board as a preliminary structure. During these conversations, we're really hoping to have a robust discussion about priorities within each of those design elements, so that when we reach steps 4 and 5 in this process, after you meet with finance and revenue and have that joint meeting, that we can start to talk about adjustments that might be needed to those plan design components. So the goals of the presentation today are twofold, kind of like getting that deep understanding of the recommendations and in those plan design components, and then starting to talk about those priorities. Next slide, please. And here are the levers that the committee will have to influence the cost and breadth of coverage through benefit design. Again, this is a refresher. We talked about this at the last meeting. To reduce or change the covered benefits, to introduce cost sharing, to restrict provider networks, and impose utilization management. So as we have conversations over the next couple meetings, we'll want to keep those in mind. We're not going to be using any of those levers today, but we want to learn what the committee thinks would be the priorities if we did have to use any of those levers. And then this is just a reminder of where we are in this process for this first phase. We're here in December reviewing benefits. And as Debbie mentioned, we'll be talking at the end of this meeting about our next meeting in January. Thanks, Debbie.
Thank you, Morgan. As Morgan previously introduced, we've brought in some extra assistance from Health Management Associates to help provide some information. Anya Roder-Wallach is one of 2 members of the HMA team that has been working to support the governance board committees. I'm going to just briefly share a little bit about the knowledge and experience that she brings to this effort. She's a principal in HMA's Boston office and brings 35 years of experience serving as a member of high-profile groups tackling health policy issues. Her range of experience includes extensive service in state government. In Rhode Island, she served as acting secretary for the Executive Office of Health and Human Services, director of Health Source Rhode Island, Rhode Island's health insurance marketplace, and Medicaid director. In Vermont, she led efforts to reform healthcare delivery and payment systems as a special assistant for healthcare reform to 2 governors. She also chaired the Green Mountain Care Board, Vermont's healthcare regulatory body. She serves on several boards and committees, including One Care Vermont, the Millbank Memorial Fund, and the Institute for Clinical and Economic Review. Thank you, Anya. I'll turn it over to you to give us some background.
Okay.
and the benefits and the PEB plan. And then after her presentation, we'll have a short break before discussions. And then if you have any questions during the presentation, please raise your hand. Anya, are you okay responding to questions during the presentation, or would you prefer to wait till you are?
Sure. Yeah, no, I'm good with that to a certain degree. And if it gets out of control, we can try to rein it back. But given that this is a relatively small committee, let's try to do it that way as long as it works.
Sounds good.
Okay, I am Anya Rader-Wallach. I am, as Debbie said, I'm a principal at Health Management Associates. I did not expect that flowery introduction, so thank you. I use she, her pronouns. And I just want to make clear at the outset that, well, several things. One, I have no vested interest in what this committee recommends or what the larger body recommends. And so I'm trying to give you information to feed your decision making, but know that that I don't have a particular agenda. I think there are trade-offs to be made. I'm going to try to make clear kind of what are the general lines along which you can make those trade-offs between what consumers pay and what's covered through insurance, which in this case, in terms of what you're designing, is taxpayer support for the program. I am not particularly a benefits expert, a benefits comparison expert, but as Debbie just said, I have been a Medicaid director, I've been an exchange director, so I have some familiarity with kind of the rules of the road for both of those programs and a fair amount of familiarity with Medicare as well. So with all that as background, just to say, like, if you think I'm trying to drive you into any particular decision, please know that I'm not, but also feel free to let me know if it sounds like I am. I think in general, what I'd like to make clear through this presentation is that you can slice and dice, and you'll see, particularly in terms of benefits in the commercial market, which includes PEB and OEB, you'll see you can slice and dice in lots of different ways. You can get really complicated about how you shift costs or control costs. But there aren't a whole lot of differences. There's sort of this fundamental concept of how much do you load on the consumer versus how much do you load on insurance, which you can pay for right now through premiums. You could pay for in the future through taxes. That's how we pay for Medicaid now. That's how we pay for Medicare now, to some degree. But the complexities that I'm going to show you in these slides, where you're going to see like mind-numbing detail about the limits on this benefit or that benefit, are not really what's most important. What's most important is how much do you want to load onto the consumer versus how much do you want to pay through the program, whether it's premium based or tax based. And there's a lot of dancing that goes on in the market now to try to kind of, I think, sort of obfuscate those issues. So with that said, let's march on to the meat of this presentation. So just to recap, the deliverables that are expected from this committee in your charter are final recommendations on benefits, eligibility, provider reimbursement, workforce, and cost containment, just a few things. Financial modeling and actuarial analysis of various plan options. I don't know that you're held to the various, but financial modeling of whatever you recommend or whatever range of options you recommend. And that will, I assume, come under a subsequent contract. So HMA is fairly limited in what we're doing now. It's basically staffing the governance board and the committees, and there will be something that's more detailed, that's a larger scope contract in the future that will include that kind of financial modeling. Next slide, please, Katie. This is just a recap of what Morgan just covered, so I won't go into it except to say that, again, what we're focusing on today is number one, review preliminary structure plan design components. Next slide. So just to put what we're talking about in context, there's at a really high level 3 tools you can use to reduce or contain the total cost of this program. Who you cover, what benefits you cover, what services you pay for through the program, and how you pay providers. I told the Morgan and her staff the other day, I teach health policy, and sometimes I do this exercise called the Medicaid Director's Dilemma, where these are the only 3 tools you're allowed to have, and you have to cut like X number of millions of dollars out of the state budget, and people very quickly get frustrated because it's not a lot of fun to cut any of them. But those are the 3 tools you have. Next slide. I'll give you a few examples of how these tools get applied. And then we're going to dive right into covered benefits and cost sharing. So what do I mean by covered population? Well, Medicaid uses this, Medicare to some extent, although Medicare covers everybody over 65 and people with certain disabilities. Medicaid toggles this switch, particularly before the Affordable Care Act toggled this switch a whole lot more in terms of who got covered. And you can see it play out in states now that have chosen either to expand Medicaid coverage under the ACA or not. So you cover more people or fewer people. Second, covered benefits and cost sharing. Medicare uses this. I've always, throughout my career, I've been kind of a little bit mystified by the notion of Medicare for all, because Medicare isn't actually such awesome coverage, and particularly in the less recent past, didn't cover things like prescription drugs. So major categories of covered services were left out. That's less true now. Commercial plans use this in the sense of applying tiered copays for drugs, for example. So you pay more if you use a drug that's more expensive or might require multiple layers of approval. Provider payment, both Medicaid and Medicare use this. Medicaid in particular, again, having been a Medicaid director, this was our primary tool, particularly after the ACA, when there wasn't a whole lot you could do if you were an expansion state to restrict coverage of the population. There weren't a whole lot of benefits that you still had an option about. You just starve the providers until they cry uncle, and you kind of live on that edge of how little can we pay and still get away with it. And a more general example would be DRG payments, which both Medicaid and Medicare and now commercial payers use. So it's basically, what are the categories of services, who bears the cost, who's covered, and how low can you go with provider payment? Those are the ways that, in general, the existing programs and plans tend to try to limit the cost of the total bill. Next slide, please. So as I said, today we're going to focus on covered benefits, and that includes not just what services are covered, which is kind of in some ways the easiest of the decisions, because as you'll see when we get into a comparison of plans across Medicaid, Medicare, and commercial, the differences in covered benefits are, for the most part, well, I shouldn't say that. They are the central part of each of these programs or plans is pretty much the same. where most of the differences occur, and I'll point out some that are significant in terms of covered benefits, but most of it occurs in terms of cost sharing, and what the people who are covered have to pay, and also in terms of how the utilization of services is managed. So are there limits on the availability of services? Do you have to get prior authorization? And importantly, are there differences between in-network and out-of-network? Because oftentimes there's a big distinction, and you'll see that again in some of the examples that we're going to cover, where either there's a big cost differential between in the network that the payer has contracted for that particular plan, or there is no out of network. So you'll see that with like some of the Kaiser plans, for example, and particularly in the OEB examples. I think you'll see that. I think we have a hand up.
Yeah, you have a couple hands up. Let's go with Helen first.
Hi, yeah, thanks, Anya. I was just hoping to interject at this point to remind this committee that we are not starting totally from scratch. That there was a joint task force on universal healthcare that preceded our board, and they came up with preliminary recommendations. And then our current governance board has set forth a preliminary structure for what we would like this plan to look like. Now, those are not set in stone. We do not have to go with those, but the board is giving direction to this committee about what we think we would like this to look like. Anya's of course correct in all of the levers that she's talking about moving, but just in general as a guidance, what the board is asking this committee to consider when it considers the benefits is that all residents of Oregon are covered, including undocumented residents, that there will be no cost sharing, there will be no out-of-pocket costs to the consumers. Of course, there are likely to be income taxes or other sources of revenue, but in terms of paying when you get services, our hope and our goal is to eliminate cost sharing in this plan. The task force recommended that we build on the PEB benefit structure. We don't have to do any of this, but that's kind of the guidance. And then there's also a value set forth in the legislation that created this board that said that any clinician licensed to practice in Oregon and in good standing can see folks, and likewise people can choose who their provider is without the limitations of networks. So that's the guidance that we have, and this committee can step outside that guidance, but the goal that we're trying to aim for is what kind of plan could we build? What kind of benefits could we offer to all Oregons that would stay within that? And if we don't want to stay within that, if we want to sort of break any of those sort of guidance parameters, why? What's the justification for it? And which ones would we be willing to break?
Understood, and that's actually the next section we're going to go into. What were those task force recommendations? So yeah, understood.
And Jim, did you have a question?
I think that my question was answered.
All right, so let's go on to the next few slides, which deal exactly with the Joint Task Force and what they recommended. So they recommended, as Helen said, that the benefits for the program you're involved in designing build on the public employees' benefits. They also, as Helen said, recommended that there be no cost sharing, which is not actually consistent with the current public employees' benefits, and we'll see that in a little bit. And that there be no restrictions in terms of provider networks. Also, not entirely consistent with the public employee benefits, not consistent with OEB, and not consistent with Medicare Advantage, which we're also going to look at. We'll also look at Medicare, kind of traditional Medicare. So in a way, what was recommended is sort of a mush of PEB, Medicaid, which is more expansive, but not entirely Medicaid, because they said we got to deal with long-term services and supports differently. And and Medicare, which is very unrestricted, unlike Medicaid, which has some network restrictions. So it's kind of like it was called PEB, but in a way I don't think that's quite accurate. So we'll talk through what that means. The one other thing I want to note on this slide is that there are some restrictions on behavioral health in the PEB plan, and the Joint Task Force recommended that that coverage be expanded, and that savings that might be achieved through this program be applied in part to that. Next slide, please. The task force recommended that the benefits be equitable, comprehensive, inclusive, and found again that the PEB benefits were the ones that they felt most comfortable recommending. Those include the ACA's essential benefits, which most plans we'll talk about today do. And I guess there were certain restrictions in the Oregon Health Plan or Medicaid, in particular infertility services, that they felt should not be included in the plan. So for this reason, the task force recommended PEB as the basis for its benefit package, but again, kind of went beyond that. Next slide, please. This has to do with long-term care. The task force recommended that long-term care not initially, at least, be covered, but that there would be some coverage of SNF, skilled nursing facility services and home health care, and that there be direction to DHS to study how the plan could further integrate long-term care in the future. Next slide, please. Just as a baseline, we're going beyond the essential health benefits in pretty much everything we're talking about today. And certainly your task force did in terms of their recommendations, but just so you have this, these are the 10 categories of benefits that are required to be provided by any plan that's on either the federal or a state-based exchange. You'll note probably one of the most important ones might be, well, there's a lot of important ones, but 9 and 10, I think, in terms of sort of the relationship to historical plans. So prevention and wellness and chronic disease management was highlighted as something that has to be covered. And this had an impact on Medicare after the ACA in terms of covering some preventive services that had not ever been covered before. And then 10, there was a choice made to cover pediatric, dental, and vision, but not adult dental and vision. And in general, what you'll see, and I want to note this now, even though it may be a little sort of out of order, you'll see that I note on some of the slides that, for example, PEB does not cover dental. What I tried to do in this presentation was compare medical coverage to medical coverage to medical coverage. PEB and OEB and lots of employers cover dental and vision, but often do it through a separate plan. So you have to elect that as a separate plan. And you've got a separate dental insurance product. So just wanted to clarify that. Next slide, please. Oh, and I should just say on that last slide, those essential health benefits do not apply to self-insured plans, although self-insured plans, if they cover any of those 10 essential benefits, cannot put either annual or lifetime limits on those categories of benefits. And I see we have a hand.
Thank you so much for raising your hand, Celicia. Just an FYI that in order to interact with the committee, you do have to submit public comment. So we don't actually take questions or comments from the public during the meeting. So thank you very much, and please feel free to reach out after this and I can connect with you on how to provide public comment. Thank you.
Okay, now we're going to go into some background on benefit comparisons before we go into the side-by-side super detailed stuff. We're going to start with the concept of actuarial value. And this isn't because actuarial value is like gospel or anything. It's because in terms of sort of pricing benefits, I think it's really important to understand that it all fundamentally gets down to this balance between what does the consumer pay versus what does their plan pay. In the context we're in, that could be a commercial plan where the consumer is paying a premium and the consumer is paying a little or a lot out of pocket. It could be Medicaid where the consumer is paying nothing out of pocket or virtually nothing out of pocket, and the plan is paying for basically everything. It could be Medicare where the consumer is paying a fairly hefty load, a lesser load if they're in Medicare Advantage. But that concept of the balance between what do you pay out of pocket versus what gets covered through the program or the plan is just sort of, I think, helpful as a framing mechanism for understanding what are the what's one of the big trade-offs you're making, not all the big trade-offs, but I think Betsy has her hand up.
Yes, yeah. Betsy, take it away.
Thanks. Can you tell us, it may be yet to come, but at what point does the cost of administering the benefits is that valued in? Because it seems to me that this balancing act in a for-profit health plan that has a lot of employees and mechanisms that it needs to pay for may be significantly different from the cost of administering, say, Medicaid, or not. So I'm curious if that is part of your thinking.
So I think you'll get into that in a lot more detail in future discussions and presentations. But fundamentally, if you think about, so there's an insurance dollar, right? Or a program dollar, a Medicaid, a Medicare program dollar. A certain amount of that goes for administration. In the commercial insurance space, you have this concept of medical loss ratio. So how much goes into administration versus medical benefits? What I'm talking about today really has to do with the you know, say it's a 90% medical MLR, medical loss ratio. This would be the 90% that we're dealing with. It's not the administrative cost. So it's a really important question and consideration because those medical loss ratios in the commercial space can span quite a range. And the government programs often, it's really hard. And I think you'll see this when we get to the point where my colleague Janine and I are presenting information on this. You'll see it's really hard to get apples to apples comparisons. But in general, the data and the literature suggests that the government programs have a much lesser administrative load, and commercial plans tend to have a higher one. Robert?
Yeah, I just wanted to add, since I'm an actuary, I thought I'd throw in. So yeah, medical loss ratio is like from the perspective of the insurer or the organizer of the plan and the benefits. Actuarial value is something that's from the perspective of the consumer. For every dollar that I incur in medical costs, what percentage of that is my plan paying? And what percentage am I paying? So if you have a 70% actuarial value, that means basically 70 cents out of every dollar that you incur is paid by your plan, and you're paying 30%.
Yeah.
80%, you're paying less, the plan's paying more, and so. But that's like, yeah. I don't have to say more. But that's I like that way of understanding it.
I do too, and I'm writing it down so that I'll use it. Can I steal that? All right. So yeah, so I think actually Robert just kind of summarized this slide quite well. So actual costs are going to vary based on your use of services. Covered benefits will vary based on who you're covered by. But there is this balance between what gets paid by the consumer versus what gets paid by the plan. Next slide, please. And I think Jim has his hand up.
Oh, okay. I wasn't seeing my hand come up, and I just kept talking.
I see it.
So it seems to me that that's a pretty limited concept. If you have a medical plan that will just hypothetically only pays for inpatient hospital care and only pays for a narrow range of physician services, but pays at 100%, it'll have 100% actuarial value compared to, say, the PEB, which is paying, say, we'll say 85%, but covers a huge gamut of services, relatively speaking.
Yeah, I think that's valid. And what we're looking at today is not super limited plans. And so I think your comment is very relevant in the sense that those much more limited plans have become more prevalent in the market. It's not the comparisons we're looking at, in part because, you know, the starting point for your discussion is a pretty rich plan. But you're absolutely right. If you got into a really super high deductible plan that had, I mean, they all have to cover the essential health benefits in the commercial space, in the fully insured commercial space. But I can imagine a scenario like what you're suggesting to some degree. I don't think
Well,
it's
I'm not saying that it exists, just that in terms
Yeah.
of understanding conceptually what we're talking
Yeah.
about.
Yep. Okay. All right, next slide, please. I don't want to take us too long. So again, the concept is you take the cost of what you're covering, you multiply it by a ratio of what is cost sharing versus what is premium, and that's your actuarial value. In reality, the cost of covered benefits is moderated by a couple of other factors, and you'll see this on the next slide. Utilization management and network restrictions, I think, are the biggest ones where, you know, if you have different cost sharing inside a network than outside a network, that's a big deal, and it affects the actuarial value. If you can only get your benefits if you say "Mother, may I," or you jump through prior authorization hoops, that's a significant thing. So here, just to sort of take the simple concept to its most complicated, probably not even its most complicated, but this is the federal actuarial value calculator. And you can see how it quickly gets much more complicated than just what do I pay versus what does my plan pay. And so there are things on this such as, you know, within my network versus out of my network, if I choose this level of drugs versus that level of drugs, if I choose a narrow network. So there's a lot of factors that go into determining what that overall benefit cost is that then gets split between the consumer and what we sometimes call the sponsor. Next slide, please. Just to recap, plans trade off coverage of for cost sharing and utilization management. Small and non-group plans in the commercial fully insured market must cover the essential health benefits. And the task force chose PEB, I'd call it PEB Plus, which is a relatively comprehensive, generous plan. Next slide, please. All right, now we're going to go into the like excruciating detail. And I actually won't take you through all this. I provided all this detail, and some of it is impossible to read on a screen, and so you will need to like download the slides and zoom in. But I wanted to just give you as much information as possible about how does PEB compare with these other potential models. And so we're going to start with PEB. Next slide, please. And what you're going to see, and this will be true for OEB too, and so I'm going to actually end up just like sort of skimming through a lot of these. Because there isn't a whole lot of point in going into like what's the difference between this deductible and that deductible. But what you'll see with both PEB and OEB is there's a whole lot of options. Some of them are include in-network and out-of-network in the case of PEB. Next slide, please. Let's just keep on flipping through and you guys can see this. And, you know, there's an array of what's covered with no deductible, what's covered with a deductible, how much you pay. Again, it's kind of mind-boggling. And I think most of you, if you're covered by employer insurance and have an array of options, or if you've gone on a health insurance exchange, you quickly think, how do I make sense of this? Like, it's just, it's ways in which the insurance companies are trying to get at some sort of control on the overall cost of the program, and they slice it and dice it in different ways. And some plans have much broader coverage through the insurance mechanism. Some plans have much heavier reliance on consumer cost sharing, and then there's kind of everything you can imagine in between. So I'm not going to go into that partly in the interest of time, but that's kind of the message from all of this. And again, I invite you to look at this, ask me questions either today or later when you've had a chance to visit it in detail, but it's kind of mind-numbing, and I think to me is illustrative of like the big message is there's a lot of flavors of ice cream and they aren't all that different. But you can find a flavor that's a little bit more satisfying. Next slide. Again, just going on and on with these options. Next slide, please. And let's go all the way to the OEB, Katie, if you could. Okay, wait, stop, sorry. So what I would say in summary about PEB is expansive benefits, like the categories of things that are covered is kind of as expansive as you can get. There's moderate cost sharing, but it depends on which one of those options you choose. There are, in some cases, increased cost sharing for out-of-network services. And in most cases, there's tiered prescription drug plans. So, and this is particularly, Janine and I do work in healthcare cost control for states, and prescription drugs are now like 20 to 25% of overall healthcare costs. So the tiered prescription drug thing is not a small deal in terms of trying to limit the cost to a plan of those prescription drugs and trying to drive people to use lower cost drugs rather than some of the newer, really super expensive ones. Gabe.
Thanks. Yeah, and just to quickly review, after looking over those PEB options, you know, they all have these sort of in-network and out-of-network options, but the parameters that we're starting with for this for our plan assume that there won't be in or out-of-network providers, right? Anyone licensed in the state would be part of the network, And we wouldn't have this in and out sort of dichotomy.
Right, and that's part of the reason I say it's kind of PEB, but it's kind of PEB plus. It's like no network, no cost sharing, and more expansive coverage of mental health. I think were the three big ones, if I'm not missing anything. The three big differences between PEB now and PEB as it might be under this plan. Yeah. Eve.
So my assumption is if we don't have any in versus out of network providers, then all of the rates are set by the plan and everyone is just paid that, because that's the thing about in and out of network providers. In network providers agree to take the rates that are contracted with the insurance company. Out of network providers say, no, thank you. I want to be paid more than that. And then the cost goes up. So my assumption is that we wouldn't have the option for a no, thank you, I'm going to charge you more. If you want to bill the insurance company, you agree to the rates. Is that what the original board was thinking about?
So I actually might have to phone a friend in Morgan to tell you what the original board, or maybe Janine, who staffed them, on what they recommended around provider payment. But provider payment is a future conversation for us, and I think it's not just about what's the negotiated rate and do you take it or leave it, but also sometimes there are sort of expectations about referrals or other kinds of things that might in theory affect cost. But the base assumption is, yeah, the network has negotiated one rate. The out of network has not negotiated that rate. Doesn't necessarily mean they have a higher rate, but it means that they're not locked into what that rate is. Tony?
Yeah, thanks. I think some of those questions just recently brought up are good to ground us again. And I really appreciate this presentation. But I think a recognition that, and I really appreciate Chair Belanca's comments on this. So we're not starting from scratch. And what I think the effort that I'm hoping we're moving towards is moving past some of the tools that we are in the status quo, and that initiative 1089 is to move us to a place where we are going to find greater equity. The laundry list that we just mentioned of the cost sharing and all those different mechanisms, that's not eligibility. That's not a list of benefits. That's a list of cost sharing and tools that we use for utilization management. Yeah. Which we all know leads to barriers. So the premise, as far as, to start thinking about the covered population and the question of what we do that for Medicaid, as you mentioned. But the tool here is all in network, right? So it's one of those, it's kind of funny for us to put together for this. And I think it's important for us to say that hopefully the idea here is we're moving past that and some of these tools, whereas the question about the medical loss ratio, that's where the bang for our buck is, right? And getting rid of 20% and moving it towards an efficiency in a system of 3% and removing waste and fraud in that. Just a reference from my remembering is that the 770 task force had wanted to maintain the integrity of the provider payment as the status quo. That's not where savings would come from. And that might be a starting point for us.
Yeah. And yeah, and I didn't put on my list of the three tools you had, I put covered benefits, covered population, provider payment. I did not put administrative cost. So I think several of you have highlighted that as a sort of a lever you can toggle. I do just want to say, like, if you want to cover everything with no cost sharing, you need to come to grips with what's the cost of that going to be. I feel like I wouldn't be speaking my truth if I didn't say that. And if you wanted to cover everything at no cost to the consumer, and you want to have rates that are not Medicaid rates, then you're going to be looking at a large bill, and that may be what you want. I'm just trying to get at what are the trade-offs. So, Jim.
So, I'm coming off of our plan just transitioned to prescription drug carriers, and we spent about 2 months, 2 meetings a week, going through about a 15-tab spreadsheet detailing in the most minute detail covered drugs. And, I think this presentation would be a whole lot more helpful if we could kind of focus on the margins, where the plans differ, because they're all going to cover hospital services, they're all going to cover basic physician services, the ACA covered services and stuff, but things like habilitative care, mental health services, alternative providers, those kinds of services on the margins. And Medicaid, I'm not as familiar with it as you are, but Medicaid covers a whole range of services that are not covered in traditional commercial plans. And I think we'd be a whole lot better served if we could kind of hone in on some of those differences.
So I think that's a really good point, Jim. And I think that that's what we're going to try to get at in the discussion at the end of this meeting is sort of what do you want to put at the margin if you want to add, or if you have to make trade-offs, like what are those things that should be at the margin? And 90% of my presentation is not going to be relevant to that, but we thought it was important that you nonetheless have this kind of baseline to know what's out there today, what's the sort of craziness that is currently in the market or in programs. And I think if you get to the point where you say, you know what, 90% of this doesn't matter, and what matters is this, then we will have made progress today. So, okay, let's move on. Next is OEB. Again, a whole lot of detail here. I think one overarching difference between PEB and OEB is that OEB can vary. The array of these options that you have from school district to school district can be different. So there's a whole boatload of plans, but you don't get to have access, as I understand it, to all of those in any given school district. It also seems to me that there's a whole lot more of sort of locked-in network. So you'll see there's a lot more stuff that says NA or not covered in out-of-network. So I think network becomes a much bigger deal in OEB than it is in PEB. And with that, I think I'll just have you, Katie, please flip through all this detail. Again, you guys can look at it at your leisure. Here's a comparison. We'll go back to that last slide. This is a comparison that it's old. It's from 2015. But I thought it might be, for the geeky among you, it might be useful to see. It was developed by Wakely Consulting Group, which is now part of HMA, actually. And the part that's interesting is you can see at the bottom, like if you really want to geek out, you look at sort of the pluses and minuses up above, and then you can see what it does to change the premium at the bottom. Just so it gives you a kind of a sense of magnitude of how much these things make a difference. And bottom line is, surprise, they don't make all that much of a difference. Now, let's go to the next slide, please. Okay, so OEB, again, fairly expansive benefits, moderate cost sharing, increased cost sharing out of network, or there is no out of network for some of their plans. Options are limited, as I said, in some school districts, and again, tiered prescription drug benefits, which is becoming more and more meaningful. Next slide, please. All right, now we'll get into Medicare. We're going to look at two flavors of Medicare. One is traditional or original. And again, this is the one where I get a kick out of the fact that people say Medicare for all, and I think most people who advocate for Medicare for all actually wouldn't want this to be the coverage that they would get. So most important, I think, is over on the right to see what gets covered. So your Part A premium is usually free. I should know what why it's qualified as usually, but you do as a consumer over 65 pay a Part B premium. So Part A is hospital coverage, Part B is all other providers. Medicare only covers 80% of the cost of most medical bills, so you have 20% co-insurance for most bills. There are annual limits on some things, but not on everything. So you can actually have a whole lot of exposure as a consumer on a year-by-year basis. Does not cover drugs, but you can get a Part D drug plan. I'm not going to go into that because it would take us all night. And importantly, there are no limitations in terms of what provider you can see. Any participating provider in Medicare is available to you under original Medicare. Next slide, please. And I should note, in terms of provider payment, that other lever that we talked about, provider payment is pretty much uniform across the country. There are some variations, but in general, there's a provider payment schedule under Medicare, and that remains the same across the country. Here is an example of some Medicare Advantage plans. So Medicare Advantage is Medicare Part C, and that is managed Medicare. Which means that the federal government pays a monthly payment to a managed care plan, and they administer your Medicare benefits. So instead of signing up directly with the federal government, and the federal government makes all the payments for all the services that you receive, you sign up with a Medicare Advantage plan. And the reason, well, one of the major reasons people do that is because under that payment structure to the Medicare Advantage plans, to the managed care plans, they often provide for less cost sharing or no cost sharing and increased benefits. And I'm not going to go into this in a whole lot of detail. But let's just say it's not entirely based on savings. There's a large portion of that that has to do with how the industry has advocated for payments under Medicare Advantage plans. And there's been a lot of controversy within Medicare about how those payments are structured, how much the plans get. But nonetheless, Medicare Advantage has become, it's now, let's see, I have some stats here, 54% of Medicare beneficiaries nationally are now in a MA plan, so-called MA plan. That varies from 2% to 63%, depending on what state you're in. And the most recent data I could find for Oregon was 2021, that 49% of Medicare beneficiaries were in an MA plan. So this is certainly where the market has been going, and given changes at the federal level, probably will be encouraged even more in the next few years. Next slide, please. Next slide. Okay, so Medicare limited benefits, heavy cost sharing, no network limits in original Medicare, but there are network limits in Medicare Advantage, and there are more benefits and less cost sharing in Medicare Advantage. And again, I think it's important to point out that that's not like a one-for-one. It's not like the network limits in Medicare Advantage or the negotiated provider rates in Medicare Advantage have necessarily saved enough money to pay for all the benefits. There's a different payment structure, and so I want to acknowledge that. Robert.
Yeah, I just wanted to say around this no network limits, because maybe there were a couple of comments earlier that a similar sort of thing applies. It's not entirely true that there are no limits. It's like there's no limits to providers who have decided to accept Medicare.
Right.
Right. And so it's sort of like the limits are self-selected out by the providers themselves, which I think is important to note that the plan that we're working on, that is not the case to an extent. Like there's still the idea of like, are you going to open up a provider office in Oregon or not? But once you do, you're a part, and like, so the limitation is more like making sure that you have providers who are coming to the state and who are qualified in the state to provide the services you're covering.
Right.
And that
Very
that
similar
is
to
a network
Medicaid.
limitation. Yeah.
Right, right. Very similar to Medicaid, but the payment levels generally are a little bit higher than Medicaid, lower than commercial, and so not quite as many providers who absolutely refuse to participate in the program. But particularly if you look at something like behavioral health, there are a lot of providers who say, I'm not taking any of that stuff. I may not even take your commercial insurance because the payment's too low and the hassle factor is too high. Eve.
I think this is an important point for us to understand, because if we're setting rates, and I had thought rates were going to be somewhere between Medicare and commercial. I don't know the exact percentage, but I had thought that had been the original recommendation. So I'm not suggesting that we shortchange providers. I want to be really clear about that. But what out-of-network providers do, which they are allowed to do because they're not contracted, is they balance bill patients. So they say, I'm going to bill the insurance company. The insurance company then pays their rate, and the provider says, well, I'd like to be paid a couple $100 more, and they bill the patient. So I haven't heard if that's going to be against the rules in our plan. I do think that balance billing is an important thing for us to talk about. And if balance billing won't be allowed, which I think my assumption was it would not, then providers who build this service would have to be willing to accept the rates.
Right.
Right. And like I said, it's not about shortchanging providers. I want to set rates that are affordable for providers. I run a primary care clinic, so I don't want to be shortchanged, but I think we have to understand that in order to understand the system we're developing.
Good point. And Morgan and company, if you could add that to the list of considerations, that would be great. I see Christine.
Yes, thank you. I mean, in response to that question, my takeaway at the last meeting was we would be changing providers' licensing such that you're not going to get a license to practice medicine in Oregon if you do not take this plan's payment and this plan's payment only. My notes from last time were doctors, providers will not be able to accept any payment that is not this plan. So my immediate takeaway was I can think of a lot of doctors that are just going to quit doing business in Oregon if they're not paid enough money. So that is a primary concern of mine.
Okay. Next slide, please. Whoops, sorry. We have Helen has her hand up.
Sorry, I just wanted to respond to that really quickly, just to clarify. Yes, all clinicians would be required to accept the plan. There are other payment strategies available. So from the get-go, we've understood that there might be a supplementary plan available by which providers could provide services not covered on the plan and get paid through a plan benefit. So it's not as exclusive as that, but they just can't, they can't, insurance companies can't exist that cover the same benefits as on the plan. But they still could provide services not covered and get paid in a different mechanism.
Thanks. Next slide, please. I think we're moving on to Medicaid. Okay, next slide, please. Okay, so Medicaid, just to be really quick about this, Medicaid is the most comprehensive in terms of the benefits covered, except you'll see that there are some exceptions like fertility services, no cost sharing, basically no out-of-pocket costs. Certainly that's true in Oregon. I think in some states they try to impose nominal cost sharing. Next slide, please. Oregon is a managed care state. Most states are, but not all. And so most Medicaid beneficiaries choose a plan and therefore are in a network, and their services are not covered outside of that network. I assume, I don't know this for sure, but I assume, as in most states, there are some people who are actually exempted from that. Very complex individuals with very complex needs are still on fee-for-service and have no restriction in terms of provider network. You can see that there are some pre-authorizations required, but pretty minimal restrictions in general as long as you stay in network. Next slide, please. And down there at the bottom of this page, you can see the things that are not covered: cosmetic surgery, infertility, non-emergency care outside the US. And you can see that actually there's a list there of stuff that is covered, which goes beyond what most commercial and Medicare coverage would cover. And the biggie there is long-term care, long-term services and supports. Medicaid is essentially the only payer that covers that in a really meaningful way. Next slide, please. So to summarize, Medicaid has the most expansive benefits in general, including long-term services and supports and adult dental. So I told you, in general, I was comparing medical to medical to medical, and dental in the case of commercial insurance is sometimes offered by employers, but it's a separate plan. In the case of Medicaid, adult dental is in there. No cost sharing for the most part. Network limits, I said either de facto through managed care, so you're in a network, and if you go outside of that network, your services aren't covered, or you may find problems finding a provider due to low provider payment. The real weak spots in most states on this front are dental health, oral health, and mental health. Very hard to find in most states to find a dentist who will take Medicaid, and to find in particular psychiatrist, child psychiatrist, some of those really important providers because of low payment rates. So that's the Medicaid summary, and I think we're at the end, and we go to our discussion, and hopefully I'm somewhere close to on schedule.
Could you please put that last slide back up?
Sure. Oh, sorry. Yeah, I don't know how I missed that in my flipping of slides. Yeah, so this was my attempt to just sort of in super simple terms compare all of these. So in terms of covered services, not a whole lot of difference, but you know, again, as Jim said, you know, there may be some meaningful things at the margin that you want to consider. And you know, PEB covers infertility, Medicaid covers long-term care. Otherwise, the array of covered services tends to be pretty much the same across all programs and payers. Cost sharing can differ quite a bit. I have grossly simplified when I say modest cost sharing and minor differences from PEB for and modest cost sharing for Medicare Advantage, I'm grossly simplifying in the sense that there are, as you saw, like a vast array of ways that you want to split out your cost sharing. But Medicaid does not have cost sharing. Restricted provider networks is pretty much the rule. In some cases, you have a choice. In Medicare, in traditional Medicare, or whatever the other word I used for Medicare was, you don't have that restriction, although important point was just made, providers can choose not to participate in the program. And utilization management, again, pretty much present everywhere, but the degree to which it's applied varies, not just across plan type, across the 5 columns that you see here, but also within each of those columns in terms of the specific plan that you choose. There could be more or less utilization management. Okay, now I think I'm done. More questions?
I see Christine and Helen's hands up. Christine, I'm not sure if yours is up from last time or if you had a new question, but feel free to go ahead if you do.
Oh, I think it's from the last time. Me.
Sounds good. We'll go to Helen then.
Anya, can you explain the differences among these plans regarding behavioral health? I didn't really hear much about that, and
yeah,
the benefits offered.
Yeah, so I didn't say a lot about that. There are major differences. I would say, and I'm not going to go into the specifics of these plans, but I'm again going to give you kind of concepts to deal with. So I think that there are 2 major dimensions on which behavioral health benefits can vary. One is outright limits. So you only get X number of visits per year. We have, yeah, I mean, that's the major one, like limitation. And I should say, this is an area of controversy. You know, the federal mental health parity law passed. A lot of states have passed similar or even more expansive laws around mental health parity. But the evidence in the field suggests that there are still much greater limits being placed on mental health services than on other services. And so some of that is really apparent in, you know, what they actually put in their description of plan design, and some of it is a little more hidden or subtle. So that's one. Second is who, in terms of either commercial plans or Medicaid, and I assume, but I don't know, that this is also an issue with Medicare Advantage. Do the plans hire a management company that specifically manages behavioral or mental health benefits? And certainly in the Medicaid and commercial space, I've seen that this can make a big difference. You have certain companies who are just, that's their gig. They do mental health service management, and they can be quite restrictive. Some might even say draconian in terms of their approaches to how they allow or don't allow access to those benefits. So yeah, good point. I think despite the fact that we think we have parity, there's mental health still gets singled out, treated differently.
Yeah, and so you're referring to ambulatory mental health services, but there's also inpatient and then substance use treatment services. Do any of these major plans cover inpatient mental health or substance use treatment? Is kind of an area where I know we would do well to expand coverage here.
Yeah, and again, I think you'd have to look at a few a few dimensions of that. So one is, what's the coverage? I think most would say they cover it. Two is, do they have a network, particularly around substance use disorder services. I think some plans have very limited access to providers. And three, just what's the availability of providers or space in general. So I come from Vermont. I've done most of my work in Vermont throughout my career. Pretty much everyone.
Do you know what
Pretty
PEB
much.
offers in that?
What's that?
Do you know what PEB offers in that space?
I think it's covered. Again, I think the issues are more, and this would be something that you would know a lot better than me, is there capacity in your system? So that's what I was going to say about Vermont. I assume Oregon might be similar in that, like, everyone covers it. Good luck finding a bed.
Yeah.
So that in the mental health, and particularly inpatient mental health, that becomes much more of an issue than what does my coverage say.
Mm-hmm. Thanks.
You're welcome. Jim.
So the topic of mental health is a little personal for me. I have a grandson who is severely mental ill, and the mental delivery system is ill-equipped to deal with him. He's been in and out of jail, in and out of countless inpatient hospital commitments, on the street. I don't even begin to know how to imagine you structure a health plan that can, other than the only time that he thrived was when he was in a small group inpatient setting. But unfortunately, they had a zero tolerance rule. And I don't know how you manage a zero tolerance rule for people who are mentally ill. But he was back out on the street after about a year and a half. So I just sort of put that out there as a goalpost.
Yep. Yep. Totally understand. I've had similar experiences. And I think, unfortunately, on the mental health end, it's like, I mean, one thing you can do is have a plan, and this has been problematic in our sort of, not even bifurcated, our multi whatever system, that you know, if nobody's responsible for the lifetime costs and wellness of a population, then they don't, and particularly, you know, if it's a well, I won't get too pejorative about insurance companies, but you know, then they're not necessarily going to care about, are we doing what's best for your grandson today, so that he'll be a productive member of society into his future. But really, that discussion gets like way beyond the healthcare system, right? It's about corrections, it's about employment, and there have been attempts to sort of quantify the return on investment, but it's really hard in this system to have anybody kind of put their arms around that, other than a Medicaid. You know, state government does it for a certain amount of the population, and maybe if they're really progressive, they say, yeah, if we only invested here, then we won't invest there. But even that is really hard to get to. So I feel for you, Jim. Jamie.
Thank you. My comment is in the same vein. It's really important to have expansive coverage of behavioral health services when we are attempting to control the total cost of care. Every actuarial report will say that the two conditions that drive the cost of care up, regardless of what diagnostic code is being covered, which patient's being covered, what they're getting, where they're getting it, is that the cost goes up with substance use disorder and with a serious mental health diagnosis. And when they're both there, the cost just goes through the ceiling. And I would offer that La Clinica has, the organization that I'm working with, has developed a multidisciplinary team approach to this that shows total cost of care savings and some really remarkably beautiful stories of people turning their lives around, getting the support that they need, finding community, and really having their lives be changed. It can be done, but it's really important for us to prioritize that and to not have those services be marginalized, because they really truly do drive so much of the cost ultimately. Thank you.
Thank you, Jamie. Cheryl. Sorry, Debbie, I'm kind of moderating. I don't know if I'm out of line here.
I think you're doing great. I think we'll let Cheryl go and have that be the last. We will have discussion on this, but maybe have that be the last just because we're a little bit behind, but I think we're okay for one more comment.
Okay, thanks.
I'll try to make this short. So I can't help but comment on this because I spend most of my time advocating for community mental health resources. And I would agree with everything Jamie said. And I'd agree with Anya that yes, inpatient care is mostly covered by all of the different health plans, but all of the things, all of the prevention, all of the services we provide in the community are not consistently covered by all health plans. And in fact, state general fund subsidizes Medicare and commercial insurance big time. So a lot of the services that we provide out in the community to help prevent people from being incarcerated or hospitalized are not covered at all by most of these plans. And that is a problem. And I would say further with Medicare, just my own personal experience with my parents, I find it baffling that Medicare will pay for any kind of inpatient, anything, acute care, but not pay for their vision, their dental, or their hearing, 3 areas, and behavioral health, of course, four areas that definitely need attention as you get older. It doesn't make any sense to me at all.
Can't disagree.
Thank you, Cheryl. So we are going to take just a quick 10-minute little stretch break. And then let's just, thank you, Katie. I see you changing that time in real time. So you all can get a full 10 minutes and not make me have to do math live. So we'll see you back around 2:42, and then we'll talk about the small groups we'll be splitting into to do further discussion. Thank you so much, Anya.
Thank you. Good to talk with y'all.
Debbie, I'm ready when you are to begin again.
Sounds good, Katie. I'm ready. All right, everyone, welcome back. So our next section is going to be discussion. Given the size of this committee, we thought it best to have breakout groups to facilitate that conversation a little bit easier. And so we will be breaking out into groups of 5 or 6. There will be either a board member or a staff member in each group. And then we'll be asking for volunteer note taker and a volunteer someone to report out once we come back to the full committee after discussion. And then there will be several questions that each committee will be tasked with contemplating. So we will, once we break out into our groups, we'll have some time to kind of discuss about whether we support PEB as a baseline benefit plan. If not, what are some of the changes you'd like to see? Is there another exemplar benefits package that you think the committee should consider? Additionally, are there benefits that we need to potentially dive deeper into as a committee? I think for me personally, at least mental health comes up. And then if there's room to add benefits, what would be on your kind of wish list of what you'd like to see added? And likewise, if there are trade-offs that need to occur to fit within budget projections, what would you consider marginalizing or limiting? So these will be our questions to ponder in our small groups. I know I think we're probably good on time because we don't have public comment, but just to check back, Katie, what time will we be reconvening? Just so I make sure I'm...
Let's reconvene at about 3:05. So we spent 20 minutes in the rooms.
Sounds good. And this is going to be our first time doing these breakout groups. So cross your fingers for everything to be successful with the tech of that. But please have some patience with us as we, and by us, I mean predominantly Katie as she figures this out. And then Jessica, did you have a question?
Yeah, thanks, Debbie. Hi, everyone. I'm Jessica. I'm one of the OHA staff. And I just had a question about the note taking and assigning someone as note taker. Are those notes going to be submitted, or is it really just for that person to be able to keep track of the conversation and then share it out with the group?
So my thought would be to have the note taker just submit via email to Katie at that. Gosh, you'll have to give that. I think it's a UHPGB. I forget the exact email, but that one email he's talking about, we could send them there just to keep a log, but they don't necessarily need to be like the note part shared in real time in the big group. We could just have the report out. Good question. Thank you. Any other questions before we, Peter?
Hi, not a question, but just a comment for future meetings.
Yeah.
Could you give us the discussion questions before the presentation so that I can organize my notes better?
Absolutely. I'm trying to think, Katie, were these part of the slides or added on after the fact for what was posted last week?
They were a part of it, but
Okay.
I think to that point, that's a great call out that we can call that out in the pre-email before the meeting.
Perfect. Thank you so much. Yeah. So with the public meetings, we do have to get all our materials in and posted a week in advance, but we can do a better job about communicating what is posted and what the ask is. Thank you, Peter. Any other questions? All right. Well, with that, I will let Katie work her magic, and then hopefully we'll see 5 or 6 of you in another breakout room and the rest of you in about 20 minutes.
Awesome. Yes, I'm going to go ahead and open up those breakout rooms right now. For members of the public that are here, once the breakout rooms begin, you will have the option to jump into a breakout room of your choice, or you can wait in the main session until everyone returns. So without further ado, fingers crossed, let's go.
Am I in the room?
Helen,
Yes,
were you not placed, you didn't?
I was just texting you. I think I got bumped out. I was briefly in it and then it just went to this breakout discussion questions.
Will you do me a favor? Because I'm not seeing, I don't have you as an option to add to a breakout room because it looks like you're already there. So can you exit out of the room complete or exit out of the Zoom completely and come back in, and then I'll get you in that room.
Okay, thanks.
Thanks.
Katie,
Okay.
will you let me know when everyone's back in?
Yes, we should have everybody now, so you're good to take it away.
Excellent. That was a jarring pull back to the main room.
Especially in our group. Jim, I think you killed it. Yeah. So to speak.
Let me just make sure. I was sharing a screen in my small group. It's not still sharing, is it? I don't think it is. Okay. Sorry about that. All right. Well,
yes, it's still, I think it's still
is
sharing.
it still sharing? Okay.
Yeah.
Give me 1 second. Let me fix that. This wouldn't.
At least I see it.
No, we're looking at Katie's screen.
Oh, maybe that's Katie sharing,
It's
not
the
us.
screen. Okay. All right.
Okay. Got it.
Excellent.
Sorry.
My like screen to brain ratio right now is not working in my favor. I have just too many screens and windows happening. But all right. Welcome back. Hopefully, I don't know if you share my sentiments. I feel like we could have continued that conversation, for sure. So let's go ahead and report out. I actually don't know off the top of my head what number everybody is. Okay, here we go. So it looks like group 1 would have been the group that I was a part of. So JB Osborne will be reporting out for us. So thank you in advance, Jamie, and feel free to take it away.
So first, there was a little lack of clarity about what exactly PEP benefits are when there are so many columns with so many things in it. The recommendation of our group was to just look at the first column and articulate what do we have questions about from that included column that we need more details about, and then what would we like to see added that we might not see there. Questions that we had, there were some questions, confusion about what is a preventive services, what might be included in that. Some questions about fertility and alternative types of care, DME, massage chiropractic. The other consensus items that we wanted to stress is that we liked not having the deductible, not having cost sharing, not having any limitations on primary care or behavioral visits, not having limitations of network. So overall, I think we felt that PEB Plus was a good starting place, but we still had a few other questions. The things that we wanted to have more details about to make sure that they really were covered is making sure that SUD treatment, substance use disorder treatment, is robust, that dental coverage is robust, and that we don't forget to cover care management services that nurses provide, as well as traditional health workers and care navigation. I'm taking a little bit of liberty to also add something I heard at the very end, I think, which was hospice and death with dignity services.
Thank you so much, Jamie. So our next share out will be group 2, which would have been the group with Helen and Danielle.
And this is Betsy. I think I volunteered to report out, but I'm going to ask you to back me up if I miss anything because he took the notes. In general, there was consensus in our group that PEB Plus is a good place to start. I think there was consternation about the idea that long-term care would not be covered, but Helen was able to clarify that for folks who are currently eligible for long-term care coverage because of their Medicaid eligibility, that would remain, and that the intent of this effort is not to make anyone's benefits less than they currently have. So that was some comfort, and that long-term care as a supplemental insurance package would still be accessible within the state for people to buy. I think there was, we talked a lot about mental health and behavioral health and the difficulty of understanding based on plan design now what might come next. You know, we don't know what the next population-wide health crisis will be. So it's hard to know whether, I mean, obviously plan designs will change over time, but behavioral health is really important to us now, but one of our group members mentioned that was not a big deal 5 years ago. And so we all can see the evidence that's the right way to be to include it in care, but it's hard to imagine what might come next that would be important that we're not thinking about now. I think there's a little bit of concern raised about how the network, how credentialing and participating in the plan would work for some providers, and whether if rates aren't set where they need to be, we'd experience some flight in our clinician or provider population. But I think too, there's excitement amongst us, at least me and Helen, that the idea of the reduced administrative load would actually be offsetting in some way to some of those costs. And then to Anya's point earlier around the idea that there's no one payer responsible for a person's life from early life to end of life, and therefore that's part of why costs are fractured, or cost incentives are in the wrong place and care is fractured. Because if you invest in an 8-year-old, you're not covering them when they're 40. That wouldn't be the case in this kind of plan, right? Everybody's in the whole of Oregon, cares for the whole of Oregon. So that's kind of an exciting prospect. Did I miss anything, anyone?
The only thing I would add, Betsy, is one of the points you made yourself, which is that using PEB as our baseline might be sort of technically smart in a few different ways. You know, one of our group members pointed out that we have a lot of data from PEB that would be helpful in designing this new plan, but also that in terms of selling this new plan to the public, selling it as something similar to PEB might be attractive or acceptable to more people than, for example, selling something that was more similar to Medicaid. But that it might also be interesting to see the sort of actuarial cost per member in PEB as opposed to Medicaid, recognizing that there's some differences in the underlying health profiles of those populations.
Thanks for catching that.
Thank you. And then from group 3 would have been the group with Morgan.
Hi, this is Tosh here. So some of the things that our group, there are specific callouts for the comprehensive package that's provided in PEB. We probably could have used a little bit more insight or presentation onto what services are covered, because there was some kind of confusion about what is actually covered and, what could be considered in this discussion, like what can we add and what can we take out. But some callouts were made about having a robust mental health coverage in this package. Dental services, are they covered? If not, then that should be something that we should strongly consider. And maybe some clarification as to what kind of services will be covered in dental, vision, hardware, hearing screening should be covered, our hearing aids covered. Those are some of the callouts that we had specifically for this package. We did have a question about fertility services, like pros and cons of services covered, given the population, the utilization versus cost, and could it be an optional, since a lot of commercial insurances do make it an optional service. We did have some skepticism about the services such as advanced imaging or elective surgeries being covered, because and that could be offset by the administrative savings that we are talking about. But there's we may need to have some conversation about how much will that offset some of the cost implications of some of the services that we're talking about. But we did recognize that long-term care support should be crucial to this package, and if people should have access to long-term care support. But all in all, since with this plan, we need to maintain the integrity of the universal coverage, because that's the whole point behind all of these conversations, that everyone should be in, no one out. We need to talk about the financial implications, and maybe a lot of the conversation should go towards that, because we need to talk about what's palatable to the taxpayers, and in terms of the levers, what should have more priority than the others. And I think that's pretty much it. We had a little bit of conversation about provider reimbursement, but I understand that we will have some presentations in the future meetings. So I think we can leave it at for that meeting.
Thank you, Tosh. And then the last group would be group 4 with Jessica and Janine.
Hello, this is Rob. So yeah, a lot of people covered a lot of ground that we also covered. To this question 1 on the benefits package, there was we thought it made a lot of sense to start with the most benefits, which seemed to be PEB of the packages that we were proposed. At the same, including things on the margins like the acupuncture, massage, doula services, which are not like included in a lot of the other plans. But that ultimately, once the budget, trying to decide on an actual benefit package without like having budget to compare to and to be in interplay with, it's quite difficult. On the question 2, benefits needing a deeper dive, the behavioral health benefit was and substance use benefits were 2 that were mentioned. Dental was a big one, and not just dental as a sort of universal concept, but like all of the things that could go into having providing excellent dental care. Someone brought up social needs, benefits that address social needs, which is definitely considered in the Medicaid space. And there are benefits around them. And so whether there's some reason to dive further into that. And there is some emphasis of preventive services, which includes, of course, the standard preventive services, which are in the essential benefits sort of package of the ACA, but other things that are like a little more expanded in scope for the notion of preventive, like certain alternative treatments and fitness benefits and things like this, to possibly consider adding in. And then we didn't quite get to this last question. If trade-offs need to occur to fit within a budget, what would you propose to limit? But since I'm speaking, I'll just say for myself that I would limit the richness of rich people in the state. So.
Thank you. Thank you. Yeah, I agree. I don't think our group really fully got to answering that last question either before running out of time. Jamie, I see your hand up.
Yeah, I do want to call out, I appreciate that last group calling out that Medicaid, we should really be proud of what Medicaid does in the state of Oregon to cover housing, to cover food, to cover transportation. And that is not, to what I could see, specifically called out in PEB benefits. And it's not usually covered by folks like Kaiser, for example, who are, one of the groups that provides PEB benefits. And I do think it's really important, and that if there are trade-offs that need to be made, I would much rather have Oregonians be housed and fed than massaged or chiropractored. So that there may be it might be important for this group to call out that some of those, social service supports are more critical for our population's health than perhaps some of the other alternative services or complementary services, which might be lovely to include if we can. But if people are not fed and clothed, we cannot achieve health in the state.
Thank you, Jamie. Christine.
Thank you. Yeah, no, she's dead on right. And then what Robert said at the last second, for himself, we didn't talk about it in our group, but I also agree. And I wonder, there's no rule that says the same benefit package has to be offered to the same eligible people in employment group health plans. People have different benefit packages to choose from or be eligible for all the time. And I don't mean to complicate the matter, and I don't want to complicate the matter, because obviously we need to start with a baseline plan. But to Robert's point and to Jamie's point, would it make sense to create a plan design that is somehow, and I don't even know how this would work, but based on a sliding scale of people's incomes, just like the Affordable Care Act? And if you go to buy insurance on the exchange, you get subsidies if you're below certain federal poverty levels, and your insurance then is free and you don't have any copays, versus someone who's above the poverty level and their plan is the exact same plan, but they have copays. It absolutely needlessly complicates the system. Absolutely, not saying it doesn't, but at the same time, there's no point in giving benefits to people who monetarily don't need them, while preventing the plan from providing those benefits to people who do need them, because we're trying to provide the same thing to everybody, and everybody doesn't necessarily need them. So I ask, are we even allowed to consider a multi-tiered plan design, or is that just too much right now? Thank you.
Thank you, Christine. I mean, I think the short answer is we can think about and consider any permutation really, and as long as we've got enough consensus, we can certainly think about and consider certainly the, kind of that idea of the federal poverty line being taken into account. Or rather the task force took that into account with the tax structure, but it wasn't spoken about, at least to my knowledge, on like a more granular basis as far as like different tiers within the plan itself. So thank you for that perspective. Jamie, is your hand up from last time, or was it from last time? Okay, so Eve, I believe you're next.
I think wonderful points from both Jamie and Christine in terms of the need to build equity into this plan. I think that was talked about really on the financing side for who would have what potential taxation structures. But then in terms of the benefits side, if you don't need housing, why would your insurance help pay for that? And Medicaid, I will say Medicaid's pretty worried about being bankrupted over the needs on particularly housing, and has dramatically limited the folks who are eligible for that benefit compared to who could be eligible under the 1115 waiver, because they are so anxious about whether they can actually afford to provide it for the people in need. So I think that's something we have to watch really carefully in terms of what could be covered. But for sure, people who have higher social needs need more. They need a more comprehensive medical home. They need more social support services. And we should be building richer benefits in that regard for people who have fewer resources and higher social needs. I'm not sure that I would kind of call out or pick and choose certain benefits to remove, because some of the complementary and alternative medicine can reduce opioid use, and it can reduce elective surgeries and that kind of thing. So I think we would really have to think about pros and cons in terms of removal of full benefits. But for sure, the tiered structure by income, I think is a good idea.
Thank you, Eve. And Peter, I think your hand was up next, or did it just go down? Or it fell off my screen. But if you had a comment or a question, please jump in.
Well, I just put it down, but I guess
Okay.
just going back to those levers that might influence costs, there was restricting provider networks and reducing like who is covered, and we're all saying those are off the table. We shouldn't even consider that. But again, my question from last time: are incarcerated people? Do they count? Are we talking like how are incarcerated people getting healthcare under this, if this plan affects them or not?
Thank you, Peter. And I would just definitely say that, yes, I believe incarcerated people are people and deserve health care. And my assumption would be it's that they would be included in this plan taken over, as currently when folks are incarcerated within the state, they lose whatever insurance they have, and the state kind of takes, for better or worse. But my assumption would be that there would be an avenue for them to be able to get this plan as well, since it would be state funded, state sponsored. I believe, Gabe, you were next.
Yeah, I mean, incarcerated people are residents of the state of Oregon, I think. A lawyer on that one. The only other point I was going to make that everyone else is saying here about the sort of tiered structure based on sort of income or resources, like it sounds like the board is already considering in terms of the long-term care dilemma, sort of grandfathering and people who qualify for long-term care currently under Medicaid could be extended into this new plan to continue to get long-term care benefits, but then anyone else who doesn't currently qualify for that under Medicaid parameters could have this supplemental insurance option for long-term care. And to that same, these other sort of questions about other social services that we might want to include, particularly for people on the lower end of the socioeconomic spectrum. It seems like, there might be an opportunity there following that same logic. I'm a little curious for the actuarial in the room. It's so great having Robert in the room. Like we start thinking about, providing housing benefits for everyone, or even just the Medicaid people, like folks have already pointed out, like that could quickly sort of overwhelm the numbers.
Thank you, Gabe. And then I believe, Jim, you are next, and then after you, Betsy. I think you're muted, Jim.
I think in most states, prisoners are covered. I don't know if that's true in Deep South or something, but I remember in a long time ago, there was Harris Wofford ran for Senate in Pennsylvania, and his winning campaign slogan was, if prisoners can have health care, everybody in Pennsylvania should have health care. But I'd kind of like to talk on this two-tiered thing. We had a candidate running for governor in Maryland a couple of years ago, and he was advocating for free higher education. And somebody asked him, well, should the rich pay? Why should the rich get free higher education? And his response was, and I think it's a very good one, and it's something to keep in mind. I don't know how this plan is planning to be financed, but he would say, why shouldn't they? They'll be paying for it. Meaning they'll be paying for it through their higher taxes as a result of their higher income bracket. And I think we need to be careful about falling into this trap of treating people. I mean, some people, clearly lower income people, need special services. I'm not denying that. But I don't think we need to start getting too deep into tiering people by basis of income.
Thank you, Jim.
I just sort of echo what Jim was sharing, just from the different perspective of how the Social Security benefit works, right? Everyone pays into it, but how much you pay in is dependent upon how much you earn, and how much you get out of it is dependent upon how much you earn. And it is a much more progressive benefit because as a proportion of your earnings, if you have a lower income, your Social Security benefit is much higher. And that was designed that way in part so there would be broad buy-in. When, as a society, you introduce a new benefit, if you restrict it to some folks, the psychology of that isn't always, and Oregon is a special place, but the psychology of that can be, why would I support this thing that isn't going to benefit me? And so I would just, again, to Jim's point, I think the way we finance this will probably have an element of progressive taxation in it, and it should if it isn't, right? Those who have more should be paying more into the system. And I think that in some respects, how the benefits play out will shake out based on people's need anyway, right? Those of us who have care coordination is really important for folks who do not have agency literacy power in the system, less important for folks who do have those things. And so therefore thus far we've said basically we just don't, people with means just don't use those services. People who need them have access to them in our redesigned Medicaid. So I'm maybe bloviating a bit, but I also want to encourage us to think about equity doesn't mean equal, but it also, I just want to caution us not to create something where we may limit the receptiveness of the population to what we design based upon those things.
Thank you, Betsy. I appreciate that grounding back into the fact that we actually have to convince people that this is good for them. Tony.
Yeah, I just really appreciate the last couple comments to that the effect. So we have a scarce resource, and figuring out how we're going to allocate in an efficient manner across a broad population of 4.2 million people is going to be very challenging. How we do it right now is on price in the country. And so what we're trying to do is optimize equity. And what I would just call out is that people don't necessarily access healthcare because they want to. They do it because it's just part of their genetics. It's part of what happens in life. It's the roulette wheel that happens in a car accident, or you happen to have depression, or you happen to have an issue that arises that you need an intervention or treatment. And the tiering system, I think, presents some complexity. And I think one thing I would just draw us back to is a framework on how we strategize, because we're going to have some difficult conversations, what to include and what not to include. And that will come because we do have to allocate this resource unless, so that is why we have the Oregon Health Plan. Governor Kitzhaber and the group that strategized that was that we have a limited amount of money and we need to allocate it to a certain amount of people that we've decided upon. And that was a tool to do this. What we're trying to do is, include a broad coverage for everybody in the state of Oregon. So I think some of the levers we will have at our disposal, some are not, but I think in our future discussions of a prioritization of what levers we want to pull would be probably productive for our conversations to strategize.
Thank you, Tony. I appreciate that perspective. I don't see any other hands at the moment, but if anyone had anything Helen.
Yeah, so I was wondering about this tiering question too, and sort of the idea that was brought up previously was, a tiered payment system, that the plan would be free to some folks and then you would pay for it as your income rose. Setting aside that, another option for tiering would be sort of tiered benefits. I mean, sort of like what's already being done with pharmaceuticals. What does this group think about the idea that there would be a basic set of benefits, and for instance, just taking pharmaceuticals as one category, this huge formulary of basic drugs that are free for everyone with no cost sharing. But then there'd be like tier 2 drugs that are more expensive, and there might be some cost sharing with those. Like this second tier of drugs you might have to pay $5 for as a copay, and then a third tier of drugs you might need to pay $25 for or something. So tiering benefits that way, like everybody would have access to, a certain amount of basic rehabilitative services, which would cover PT and OT and massage and acupuncture. And then there would be a tier 2 of rehabilitative services that had some cost sharing. So instead of cost sharing based on personal income, you could cost share based on the extent of the benefits within each category. How does that strike people? Is that something that is worth considering?
Thank you, Helen. And then Eve, I saw your hand go up. Was that in response to Helen?
Yeah.
Yeah. Okay, go for it.
So I would prefer that we focus heavily on equity. I do support a tiering of things like pharmaceuticals in that we're going to start with this class of drugs. And if that doesn't work, we're going to move to this one. And we're not going to go to the most expensive specialty drug until we've tried all the ones until then. But to put everyone in a circumstance where in order to access a slightly more expensive or much more expensive form of care, you have to do cost sharing. I think that would be going backwards for those folks who are on Medicaid in particular and who maybe can't afford that. I do think that for me, it's the social SDOH, social determinant of health benefits that are covered under Medicaid that are the things that I think, gosh, I don't feel like that needs to be expanded beyond the Medicaid population. And it's not in the PEB benefits, but it would be a real bummer if people who are on Medicaid got moved over to this plan and then lost access to those really innovative supports that they have today in order to help stabilize their health through a healthy environment. So I think to me, that's the part that I would like to see a difference. I feel like most people would understand why housing and food assistance and that sort of thing would live with people of lower incomes as opposed to people of higher incomes. But anyway, those are my thoughts.
Thank you, Eve. Tony.
Yeah, Helen, I think that's a very good question. I think we have some constructs that would be good tools for us. So certain things that we have in our state is the HERC, which is a review board to evaluate the merits of interventions and tiers of those. I think of other places, and it might be something I don't know, and I don't recall 770 doing this, is a body that would maintain the integrity of something like NICE in the UK that does an evaluation of interventions and procedures, and are those evidence-based? Certainly having somebody prescribe lisinopril and then wanting a trade name hypertensive medication, right? We should promote the best practice of trying to use generic drugs. And so certainly setting some areas that would promote the use of those other higher cost interventions. If somebody wanted to have a trade name medication, I think that's a question we're going to have to answer and think of some tools to do that. And I just really draw back to having an entity in our state that could perhaps serve that role to answer those questions. And I would just offer up something like the HERC or something of that nature.
Thank you, Tony. Peter.
Yeah, I just wanted to kind of add on to Eve's comment about social determinants of health, and just wanted to note that we are kind of already doing some form of means testing for those benefits through OHP, and that the eligibility requirements for those benefits are not universal to all OHP members. So specifically the housing benefit, the eligibility requirements are kind of 30% of the average yearly income for the members region, and they have to kind of lack the supports to prevent homelessness. So I guess I just kind of want to note that there is already kind of some precedent for that in our current state-sponsored excuse me, our current state-sponsored coverage. And so that's just something that, I think that we can bring forth into our considerations for this plan.
Thank you, Peter. And Jim.
So kind of like everybody else here, I come from my own perspective. And that perspective is one who administers a health plan. And where I see huge savings in the Oregon Health Plan on the administrative side is, under the current system, it is so complex. And you think about it, every month, every insurance company gets thousands of files to determine monthly eligibility. That's a huge administrative apparatus that is, requires IT professionals at all ends, customer service people to respond to all the glitches that happen. So every time you talk about sort of fragmenting this system, I think of adding a layer of complexity to the administrative overhead. So a question that comes to mind on the Medicaid issue, and believe me, I'm strong, determined, recognize the value of housing as a health benefit. But could these be provided outside of the Oregon Health Plan? I just throw that out. So that's one point I wanted to make. The other point is, and we haven't really talked about this, but we've kind of talked around it. This idea of formularies and using pricing to steer people. So the really fundamental question is, are we going to prescribe a specific formulary that where the Oregon Health Plan decides which are the most cost-effective drugs to allow on the formulary? In our plans, we frequently, in the PPOs and HMOs, or the open model HMOs, get all kinds of complaints that my doctor prescribed a drug that's not on the formulary, because there's thousands of health plans in the state of Maryland, and nobody can possibly know every formulary that every health plan has. We get 0 complaints from the people that are on the staff model HMO. Why? Because the staff model HMO, they know the formulary, they know how to prescribe the formulary, they know how to work around the formulary if they need to. So you're talking about the Oregon Health Plan being one giant staff model HMO. And I think we need to be thinking about a formulary. And that's going to rub pharma the wrong way, because you're going to be telling some drugs that are not on the formulary, or you price them off the formulary in some other mechanism. Those are the 2 points I wanted to make.
Thank you, Jim. I think that was all the hands I saw. Just giving it another few seconds. So just trying to reflect back, it sounds like there is general consensus that the PEB or PEB plus is kind of a decent starting point. But I'm hearing there's concerns about potentially Medicaid beneficiaries losing out in some way if they get their benefits reduced, and which is explicitly stated we don't want to do. It sounds like there's also a lot of agreement on expanding mental health, behavioral health, but maybe some more information needed on exactly what that looks like, and certainly what that does cost-wise. And then it sounds like just kind of questions about the prescriptions and the formularies and different tiers. And then I guess the financing structure on, like, is there a benefit to doing some kind of tiering to this? And I do appreciate Jim's reflection on that this then makes it administratively more complex. Oh, Jamie, yes.
The other thing I didn't hear anyone mention or ask about, we already have sort of a state above the line, below the line systematic mechanism in place, but I didn't really see, I'm not sure if that's reflected in the PEB benefits, but similarly to Jim's point that we have a formulary, that is a good starting place. And we do have above and below benefits that are also good starting places that people have spent a long time thinking about prioritizing and using evidence to make those decisions. So that I just don't want us to leave that behind.
Thank you, Jamie. So just in the last, the last 9 minutes now that we have left, just thinking forward to our next meeting next month. Are we ready to move on to discuss eligibility, or is there more discussion and information about the benefits, which we at least started upon today? Janine.
I just wanted to add in that as we talk about the tiering and some of the complexities between Medicaid and other, is we have to think about having also supporting the Financial and Revenue Committee, that which funding streams are used to fund this will dictate how, so if you're obligated to do certain things for Medicaid in order to get the Medicaid federal match, we'll have to kind of partner with that and think about that. So we need to be thinking about that. If you're tiering by income that's different than what Medicaid might do, then it might not allow, Medicaid might not let us use those matching dollars. So just some things that we need to think and bring back to you as you start to refine this and make in order to fund it.
Thank you, Janine. Definitely an important part. All right. So, oh, Eve, missed your hand there.
I still heard a number of questions about what not being clear about what's not covered. So I feel like it's hard to say we're done talking about the benefits when we're not sure. And there was the outstanding question on fertility treatment that I think does deserve some conversation. But also just the basic things of like, if you need a hearing aid, is that covered? At what level? And some of those items that we just couldn't tell from the structure. So if someone could go through and say, okay, here are the benefits that are maybe covered in other commercial plans out there that are not covered under PEB, that could be really helpful for us to take a look at that narrowed down list and just see, are we missing something on the plan that we thought we wanted?
Thank you, Eve. Right. And Katie, do you mind just making a note? I know you're probably already making notes, but just so that we can see if we can get some of that ready for our next meeting and sent out to the groups to see if we can kind of pare that down in a way that makes it stand out a little bit more. Jamie and then Morgan.
How do we vote on this? It looks like there's a question that has a yes or no answer being posed to us. And I was just curious how we would answer that question as a group.
Thank you, Jamie. It's more getting a sense. And the sense that I am getting overall is that there's more discussion around these benefits is the overall sense. I don't think we need to do necessarily a formal vote so much as just hoping to get that we're not missing anybody or any topic that somebody was kind of left out hanging. Thank you for asking though directly. Morgan, did I see you up or did you disappear on me?
Yeah, I was just going to add, there are quite a few staff on this in this meeting that have been taking notes, and we will go back. And what I'm hearing is that we need more information on what was just said, kind of what is not covered, and a little bit more information on, in particular, the behavioral health and substance use disorders, covered services. Those in particular seemed like ones that the committee members were interested in getting a deeper dive into those benefits and really understanding because they are of particular interest. There were quite a few other suggestions, so I think we'll kind of be sifting through. And I'm also hearing that there's more information that's needed on this topic. That there's general agreement on PEB Plus, and there are still questions that folks would like some more information on. So we will be all reviewing our notes, and we'll be working with Debbie and put together answers to those questions, as many answers to those questions as we can by the next meeting.
Thank you, Morgan. All right, so just a little highlight as alluded to, our next meeting, we will get into some eligibility. And are there any specific questions that you have just out the gate that you need answered, or some background information that you need before we embark on that topic of eligibility? Eve, I see your hand up.
So I've heard the question about folks who are in carceral settings several times. My understanding is that it is currently against federal rule, that is a CMS rule, for any Medicaid or Medicare dollars to be utilized for folks who are incarcerated, with the now exception in our state, the last 90 days of incarceration transition of care services. We have a Medicaid waiver that allows us to utilize Medicaid funding the last 90 days for some specific transition of care. I would look for a legal opinion on that if we have Medicaid dollars flowing into the system, because I think we would have gone there if the federal government had allowed us in a waiver.
Thank you, Eve. Jim? Jim, you're muted.
In terms of the next meeting, since we have the understanding that this plan is to cover all Oregonians, what does it mean to be eligible, to discuss eligibility? So can you put a finer point on that in the next agenda?
Sure. It's as simple and as complex as that. So what do we mean by an Oregonian? Is there time? Are we going to go with current definitions of residency? How does that pertain if we want to cover folks who may be undocumented? Just coming out of the, kind of like the pandemic and all the work from home and how we access and where we live, where we work, where, it's all changed quite a bit, that landscape. So those are some questions. I would say, at least for me personally, from eligibility, that kind of like gray area of somebody who may be employed in the state but live elsewhere or vice versa is one that kind of pops out to me as something that wasn't considered in the task force. But really, it's the question is, how do we define this currently? Is that definition appropriate? Does it touch all the folks that we need it to? And are there any kind of like questions you have on that? Like, I think the incarceration is a big one that came up, that, yeah, are you considered a resident? Are you eligible? And now this kind of Medicaid stipulation. So yeah, so I think there's still lots of considerations around eligibility, but hopefully, I don't know, that was a few points, maybe not a single clear point, though. Hopefully that answered a little bit, though, Jim.
Well, I did a graphic once about in-state, out-of-state, so I can share it with you.
Excellent. I love graphics. I'm a visual learner. All right. Anything, I definitely think the, kind of incarcerated status came up. I think work from home comes up. Is there anything else that kind of, kind of questions that come up when we think about eligibility that that you'd want answered or explored during our next meeting?
People with partial residency. I mean, there's a lot of questions, I think.
Jamie, and then Betsy, and then Peter, and that's probably going to put us at or over time. So
yeah, migrant agricultural workers.
Thank you, Jamie.
I was just thinking about, and I think some of what you said before might be encompassed, these people might be encompassed in one of those groups, but folks who live in Portland but may get care in Vancouver, but that, they live and work here, but sometimes get care elsewhere. We have those cross-border care.
Thank you, Betsy. And Peter?
Yeah, for this question, for today's question, we were kind of using PEB as the baseline. I would guess for the next meeting, we'll be using OHP as the baseline, or I would suggest that's probably the best thing to use as a baseline. So could we please have, like, specifics, like what does OHP say about these various categories? And then we can kind of compare and contrast from there.
Thank you, Peter. And Helen, I will let you wrap it up.
I was just thinking about families who reside in Oregon and have children out of state in college, and those kids are currently on their parents' plan. That's another interesting eligibility question.
Good point. Thank you, Helen. All right. And if other questions come up, you know, feel free to send an email to the email that I can never remember. And we will definitely include that. And I appreciate all of your time. Apologies for going 1 minute over. But with that, we will adjourn this month's meeting.
Thank you.
Thank you.
Thank you all.
Thanks, folks. Bye.